Demonstration of tissue harvesting for pre-Descemet endothelial keratoplasty. Pearls and pitfalls learned from a series of ex vivo pneumodissections. All producers have no financial interest in the subject matter of this film. Pre-Descemet endothelial keratoplasty, or PDEK, is the latest innovation in posterior corneal lamellar transplanting procedures. The lamella consists of endothelium, Descemet membrane, and pre-Descemet layer, or the so-called dual layer, which has been reported by Professor Hamin and Dua in 2013. The acellular pre-Descemet layer is located between the most posterior row of stromal keratocytes and Descemet membrane and is 10 microns thick in average. This study was conducted in the wet lab of our university center. 25 human corneal tissue specimens consented for research and not suitable for transplantation were obtained in our eye bank and used for PDEK tissue harvesting. The aim of our study was to demonstrate surgical pros and pitfalls in tissue preparal for PDEK and to correlate these findings with OCT imaging and histology, which were performed on 4 selected specimens. With the donor corneoscleral rim endothelial side up, a 30-gauge needle attached to a 5 ml air-filled syringe was introduced into the mid-peripheral stroma as close as possible to the pre-Descemet layer. Subsequently, air was injected into the stroma in a controlled manner. Forceful injection caused the bubble to suddenly form and pop immediately afterwards. In most cases, a type 1 bubble that separates stroma from the pre-Descemet layer would be formed. It started as multiple small, well-defined bubbles and spread from the center to the periphery, was dome-shaped and had a diameter of 8 mm in average. The bubble size could be increased by introducing a needle tip further into the bubble lumen and carefully injecting more air. In the case of failure to inflate the bubble to the desired diameter, viscoelasticum or storage medium was injected to further increase the diameter. Attempts to extend beyond 8.5 mm caused the bubble to pop suddenly. A leaking bubble, as here around 12 o'clock, could be salvaged by sealing the perforation site with viscoelasticum or by pressure from a blunt instrument. Further viscodissection was then performed into the opposite direction. OCT imaging of the type 1 bubble showed a characteristic dome-shaped air bubble. We obtained an average diameter of 8 mm. Histology confirmed that separation between pre-Descemet membrane and stroma did not meet the limbus, as shown by the blue arrow. The yellow arrow shows the point where pre-Descemet layer fuses with the trabecular meshwork that feathers out. The bubble roof, stained with PAS, showed clearly an acellular layer underneath a dense Descemet membrane. A type 2 bubble would typically form in older donors, in which a thicker Descemet membrane can be easier separated from the pre-Descemet layer. The bubble started to form in the periphery as a small bean-shaped bubble and spread to the center. These bubbles can still serve for DMEK. In the case of a peripheral leakage, as here seen around 12 o'clock, viscoelasticum can be injected to seal the perforation site and offer further possibilities to inflate the bubble with air. OCT imaging of the type 2 bubble showed a characteristic round air bubble that measured 10.5 mm in average. The bubble roof, stained with PAS, showed a dense Descemet membrane as shown with the blue arrow, but no underlying pre-Descemet layer as shown in the left picture. Descemetorexis in a 10 mm zone as for DMEK preparal before injecting air could prevent type 2 bubble formation as first mentioned by Max Soper. This way the stromal air cannot escape peripherally into the type 2 cleavage plane. In the early stage of the formation of a type 2 bubble, the bean-shaped small peripheral bubble can be punctured and another attempt can be made to form a type 1 bubble by applying pressure on the puncture site with a blunt instrument and injecting storage medium or viscoelasticum. In the early stage of the formation of a type 3 bubble, the smaller peripheral bubble, as seen here underneath the needle, can be punctured in a